Today's topic is childhood asthma. We will be seeing the key points which will help you to score a bit more marks in your exams. First is introduction. Asthma is a disease of chronic airway inflammation, bronchial hyperreactivity, and reverse airway obstruction. It affects 10% of the population and can develop at any age, but typically half of the pediatric cases present before the age of 10 years. There is often a family history of asthma or atopic diseases. Next, we will see definition. Bronchial asthma, now regarded as a chronic inflammatory disorder of the lower airway, which is characterized by bouts of dyspnea, predominantly expiratory one, as a result of temporary narrowing of the bronchi by bronchospasm, mucosal edema, and thick secretions. Asthma is an atopic condition, and other atopic conditions are often coexistent. Example, eczema and allergic rhinitis, allergic conjunctivitis, raised serum IgE levels, skin prick test positivity for allergens, or family history of atopy. Etiopathogenesis. The factors which trigger asthma is mostly allergy, respiratory infection, emotional variation, exercise, change in climate, puberty changes. Next is pathophysiology of asthma. Pediatric asthma involves a complex interplay of factors leading to first one is airway inflammation, hyperresponsiveness, and airflow obstruction. This includes the development of airway remodeling, mucus plugging, and increased sensitivity to various triggers. The condition often arises in childhood, linked to genetic predisposition, environmental exposure, and early life events that influence immune system development. So the first one is airway inflammation. A key feature of asthma is airway inflammation characterized by the recruitment and activation of inflammatory cells like eosinophils, mast cells, and T cells. These cells release inflammatory mediators that contribute to bronchoconstriction, mucus hypersecretion, and airway remodeling. The second one is airway hyperresponsiveness. The airway becomes excessively sensitive to a variety of stimuli, leading to constriction and narrowing of the airways. The heightened sensitivity is thought to be due to changes in airway, smooth muscle function, and neutral control. The third one is airway obstruction. Inflammation and bronchoconstriction cause airflow obstruction, leading to wheezing, shortness of breath, and coughing. Mucus plugging and thickening of the airway wall can further exacerbate this obstruction. If you look into the Google, you can find the pictures of the normal airway and the asthmatic airway and the airway when in asthma attack. So it's worth checking it and looking into the pictures. So there are three types of asthma. First one is extrinsic. This is IgE mediated and precipitated by an allergen. The second one is intrinsic. This is non-IgE mediated and precipitated by a respiratory infection, usually viral. And the third one is mixed. This is usually exercise-induced or aspirin-induced. Following an exposure to an allergen which interact with specific mast cell-bound IgE, reaction occur in two phases: early phase reaction and late phase reaction. In early phase reaction, within minutes, mast cell release histamine, leukotriene C, D, and E, prostaglandins, platelet activating factor, and bradykinin, causing mucosal edema, secretion, and bronchospasm. The net result is lower airway obstruction, and pre-medication with beta-2 agonist can inhibit this phase. In the late phase reaction, this is characterized by clinical manifestation of asthma. It follows 3 to 4 hours later with release of mast cell mediators. Unlike the early phase, beta-2 agonist cannot inhibit it. However, steroids are capable of inhibiting it. So next we will see about the clinical features of asthma. The features can be chronic with frequent wheeze and cough, usually present if asthma is being undertreated, or acute with fast onset, often associated with upper respiratory tract infection. The disease varies from being extremely mild to very severe with frequent and even life-threatening exacerbations and interrupting daily life considerably. Chronic features of recurrent wheezes. Difficulty in breathing, both often with exercise if long-standing, and chest hyperinflation, Harrison's sulci, that is a permanent groove in the chest wall just above the costal margins at the insertion of the diaphragm, flattering growth, and nocturnal wheeze with cough. Second one is exacerbation. In that, there will be dyspnea, expiratory wheeze, that is babies have crackles with bronchiolitis, not infant wheeze. Respiratory distress, tachypnea, tachycardia, recession, and cyanosis. And the life-threatening attack symptoms are unable to speak or complete a sentence, and there will be central cyanosis and exhaustion, confusion, and decrease in level of consciousness because of lack of oxygen or hypoxia. And there will be silent chest on auscultation due to minimal air entry, and the peak flow test will be less than 30% of predicted, and there will be pulsus paradoxus, which is the fall of inspiratory systolic blood pressure greater than 10 mm of mercury from expiratory systolic blood pressure. How to diagnose asthma? First one is history collection from the parents and from the child regarding their family history of asthma or any ectopic illnesses, and physical examination which will show barrel chest, hyperinflation, and wheeze. And chest x-ray will be showing hyperinflation, flattened hemidiaphragm, peribronchial coughing, and atelectasis. And in the spirometry, we have to give the spirometric chart, and we will be comparing the curve, and we can find how effective is their breathing. Next is treatment. So in treatment, the main thing is medication. The main medications used for maintenance are bronchodilators, which gives short-term relief of symptoms, and prophylactic therapy, which reduces chronic inflammation and bronchial hyperactivity. In the outpatient clinic, our aim is to titrate these treatments so that the child can function normally, yet still avoid any detrimental effect on growth and development. So in bronchodilators, short-acting beta-2 agonist, which is salbutamol and terbutaline, and beta-2 agonist, which is salmeterol and formoterol, and long-acting, short-acting anticholinergic, which is ipratropium bromide, which is very useful. And in the treatment of chronic inflammation and hyperactivity, inhaled steroids like budesonide, beclomethasone, fluticasone, oral steroids, prednisolone, sodium chromoglycate, which is barely used, and methyl xanthines, which is theophylline, and leukotriene inhibitors. Good examples are montelukast and saferlukast, may reduce the amount of steroid therapy that is needed to control symptoms. And there is combination inhalers, which is containing inhaled steroids or long-acting beta-2 agonist. There are different asthma drug delivery devices. The first one is nebulizers, second one is large or small volume spacer, third one is dry powder device, and the fourth one is propellant metered dose inhalers. Next we can see the clinical management of asthma, in which if there is infrequent episodic asthma, which is characterized by 75% of asthmatic and less than 4 episodes per year. So symptom-free between acute episodes, and no regular treatment will be needed for these kind of children. And in the management strategy, beta-2 bronchodilators will be used, and treat acute episodes with use of inhaled bronchodilators and short-course prednisolone in more severe episodes. That is prednisolone for 3 days and given once daily in the morning after breakfast with no need to taper the treatment. Next one is frequent episodic asthma, which is characterized by 20% of asthmatics, and it will have episodes every 2 to 4 weeks and regular treatment is needed. So the management strategies is use beta-2 bronchodilator as required and use regular low-dose inhaler steroids. In persistent asthma, which is characterized by less than 5% of asthmatics and 3 episodes per week with cough at night or morning, regular treatment is needed for this type of asthma. The management strategy is to use prophylactic inhaled steroids. Beta-2 bronchodilator may be helpful, and long-acting oral steroids may be needed. Oral leukotriene inhibitors may enable reduction in steroid usage. In case of exercise-induced asthma, the management strategy, if it's mild, will be beta-2 bronchodilator before exercise, and in case if it's severe, go for low-dose inhaled steroids. In acute asthma attack, oxygen inhalation may be needed, and B agonist, example salbutamol, either 10 puffs from a meter dose inhaler via spacer device or nebulized as frequently as necessary. And it will be initially every 15 minutes, which we call as burst therapy, or ipratropium bromide will be 6 hourly, which can be helpful more in younger age. Systemic steroid, which is oral prednisolone 1 to 2 mg per kilogram, max dose of 40 mg, or IV hydrocortisone. If it's a severe attack, then they may need IV infusion or bolus of salbutamol or aminophylline infusion. If on oral theophylline, no loading dose needed. And intubation and ventilation if deterioration in general condition, that is peak flow and blood gases show any indications, drowsiness, tiring, and despite above measures. Next, we will see about useful clinical guides. Regarding steroids, fluticasone and budesonide are preferable since they have fewer side effects than beclomethasone. Patients on dose of steroids greater than fluticasone 500 microgram per day, budesonide 800 microgram per day, and beclomethasone 800 microgram per day should be under the supervision of a specialist clinic. Long-acting beta-2 agonist. Salmeterol may be a value for nighttime symptoms or daytime activities. Should be used as a prophylactic agent. Consider in patients on inhaled beclomethasone or budesonide 400 micrograms per day or fluticasone 200 micrograms per day. So allergen avoidance is another measure, and removal of feathers or woolen bedding, wrapping of mattress in plastic, cleaning of carpets and furniture, no pets in the house if the child is allergic to them. Next one is regarding passive smoking. No smoking in the house or car. Parents or carers must be strongly encouraged to stop smoking completely. Older patients will need to learn more about their condition and how it is best to be treated. For example, which medication to use and when. And best inhaler techniques must be taught to older kids. And what to do if asthma is getting worse. Not to smoke and gargle after steroid inhaler use so as to avoid oral thrush. Hopefully this is a key and it helped you. Thank you for listening.